Hello everyone. Thank you for joining today's Advanced APMs Overview webinar. The purpose of this webinar is to provide an overview of participation in Advanced Alternative Payment Models, one of the two tracks of the Quality Payment Program. Now, I will turn the call over to Adam Richards, Health Insurance Specialist in the Center for Clinical Standards and Quality at CMS. Please go ahead.
All right, great. Thank you, and hello, everyone. Thank you all for joining our discussion today on Advanced Alternative Payment Models, what we call Advanced APMs. This webinar is a part of our comprehensive series on APMs that we kicked off about 2 weeks ago with an overview of MIPS APMs and the APM scoring standard. It's a great webinar. We're posting that to our resource library shortly. So if you didn't get a chance to review that or participate, definitely encourage you to take a look at that webinar. We'll also have a webinar in several weeks on the all-payer combination option, which is new for the 2019 performance year. So if that's something that interests you as well, we encourage you to certainly sign up for our Quality Payment Program listserv because we'll be putting those dates out shortly. Now, today our focus is on advanced APMs. We receive a lot of questions on how we define advanced APMs and what it truly means to participate in an advanced APM versus a standard APM. So we're going to do our best to cover the full spectrum of the advanced APM track of the Quality Payment Program. But we're also eager to hear your questions and thoughts because this is the feedback that always helps us identify opportunities for additional training and resources. We'll provide a little background on APMs just to give you some context, but if you needed an additional starting point to combine with this event, I highly encourage you each to access the APMs 101 webinar from back in February, which is available on qpp.cms.gov under the webinar library. And as always, we will post the recording, transcript, and slide deck of this webinar in the webinar library in about 2-ish weeks. Okay, so let's charge ahead. And we're just going to talk a little bit about the topics, just to kind of give you a lay of the land for today. Again, we'll start with our general Quality Payment Program overview, and then we'll get into some of the specifics around APMs, how we define APMs, the design, the category elements, and then really get into the bulk of our discussion around advanced alternative payment models. Again, we hear a lot of questions on the criteria within advanced APMs. How do we determine which APMs are advanced APMs? Also, a lot of questions on qualifying APM participant status, which is the how you participate as a part of an advanced APM and the snapshot dates associating with determining that status. So we'll go through all of that information today, and of course, we'll talk about some of our available resources and then pause for questions and answers at the end of the call as our time allows. So charging on to the next slide, and then slide 5 actually, so we can talk a little bit about the Quality Payment Program. So we'll just start with a quick overview here, and again, this is our basic structure of the program. As you can see, the Quality Payment Program consists of 2 avenues for participation. We have the merit-based incentive payment system and advanced alternative payment models, which we'll discuss today. We really look at both pathways as foundational elements to help drive value. We know that many clinicians will initially fall into the MIPS side, which we anticipate will help them to build a strong infrastructure to meaningfully participate in a value-based system and really ultimately help them to move over to the advanced APM side of the program, which is what we're ultimately hoping for. And this is really where our discussion is going to begin today. So at this point, I'm going to turn it over to Dr. Corey Henderson to talk about APMs and advanced APMs. Corey?
Good afternoon, everyone. If we could go to the next slide, please. I'm going to take you through the APM overview, the APM criteria, and I will then hand it over to Trevi. Trevi is actually one of our operations leads here. He's going to talk about what it means to become a QP and the process of becoming a QP, and I'll define that a little bit more in the presentation. And then I'll talk a little bit about the all-payer, other-payer combination option, and then we'll take it back and hand it back over to Adam. So here we're going to start with what is an APM. An APM pretty much is a way that we're using an approach to pay for medical care through Medicare. We're incentivizing quality and value, and we're really looking at 4 key areas that really define what an APM is in law. The first one is the CMS Innovation Center model under Section 1115A, other than the HCIA awards or the HICIA awards, as some people heard, Healthcare Innovation Award. MSSP, or the Medicare Shared Savings Program, is also an alternative payment model. Demonstrations under the Healthcare Quality Demonstration Program is also an alternative payment model, and also demonstrations required by federal law. Next slide, please. So just want to get a little better so you can hear me better. Just adjusted the mic. Okay, so here we're going to define an alternative payment model. An alternative payment model is an approach that provides added incentive to clinicians, as we talked about quality and cost efficiency. When we talk about that, we're talking about the ways that we do it in the way of special conditions or specific conditions that we pay for, care episodes we pay for, and populations we pay for. In addition to that, we offer significant opportunities for eligible clinicians who are not ready to participate in advanced APMs. So if you look at the slide, the picture on the slide on the right-hand side, you'll note that there's a circle with 2 other circles in the middle. An APM is the overarching structure, but underneath that you have 2 smaller buckets of MIPS APMs and advanced APMs that are part of that APM bucket. Next slide, please. So let's go to the next slide. Yep. So let's talk a little bit about APM Design Elements. This is just important for you to know for background purposes to help define APMs. When people send in ideas for APM design or they think of APM design, they have to consider the APM type, the clinical practice transformation that you want to see take place, what's your rationale and evidence behind the APM, is it scalable, meaning that are we going to be able to include participants outside of just the specific participants or beneficiaries you serve? How do you align with other models and work? What's the quality improvement you want to see? And then what's the overall operational feasibility? Can this be done? Next slide, please. So as we think of the CMS model design factors, this is just a quick overview. Some of the factors that include number 11, economic impact. Some of these things are outside of the realm of the ideas that are created. We have to do that internal to CMS to really think about how does this affect the overall outcome as we talk about cost savings. Also, we have to think about number 19, availability of other payers to test the model, as we'll talk about other payer, all payer, meaning that will we be able to scale this outside of CMS if we decide to expand this idea. Next slide, please. Here again, you'll see an overview of how we help define APMs. This at the top, you'll see in the green section, APM, that is the name of the model that we're working under. So the first one would be comprehensive ESRD care model, looking at end-stage renal disease. The next bucket will be the MIPS APM under the APM scoring standard. So we already within CMS have made a determination, did this meet the regulatory criteria? The medical home model, was it a medical home model? And going back to looking at the name of the APM. Did it use of CERT criterion, was that met? Were quality measures criterion met? Is there financial risk in this model? And is it an advanced APM? So when you look at the comprehensive list of APMs, this is a great way to be able to understand what you're looking at there. Next slide, please. Next slide. So forging right ahead is some key terms that is important to know to understand APMs, advanced APMs, and overall APM structure. In advanced APMs, the first term is APM entity. This is the entity that participates in the APM. The easiest way to think about that is that entity often has its billing, it bills for NPIs, it bills for clinicians. The advanced APM term, and the advanced APM goes back to the definition that we used earlier as we talked about CERT use. basing payment on MIPS comparable quality measures. And we'll get a little bit more into that when we move ahead. Affiliated practitioner and the practitioner list, those are just your practitioners that are assisting in the work done in the APM. MIPS APMs, this is going to be not the most advanced APM participants, but participants that's still doing work in the APM under the auspice of the MIPS APM. We're going to give them criteria and credit for the work that they're doing so they don't have to do duplicative work and reporting in MIPS, and they're going to get the APM scoring standard benefit. And you'll get more definitions as we go along and better understanding in context. The participant list is going to be a list that we actually keep a list of all the participants in your advanced APM from your entity. And then the QP, we'll define this a little bit more, but Trevi is actually going to give you a better understanding of how to become a QP. But this is where you're eligible to receive the APM incentive payment and is relevant to your QP payment amount and your QP patient count based on a threshold amount for that year. Next slide, please. So this is a great slide that kind of helps you see the overall structure of what we mean by APM entity. You'll see the word 10 under the word APM entity in this box here. The 10 just is your tax identification number or the way that you bill, and CMS uses that for billing purposes. But in that APM entity, you have NPIs, or the National Provider Identifier for your clinicians. These clinicians assign their billing to their APM entity, and their APM entity then sends the bill in for the work that's done under it. So it's important to note that the APM entity is nothing more than an entity that participates in the alternative payment model or the payment arrangement with a non-Medicare payer through a direct agreement or through federal or state or law or regulation. Overall, the APM entity is just a group that does the billing. Next slide. Next slide, please. So let's talk a little bit about advanced APMs, and we'll start here with the rewards and the risk. One of the key benefits of being an advanced APM is that you receive specific rewards for being in the advanced APM. But then you also are eligible to receive a 5% incentive payment. That 5% incentive payment is based on the fact that you take on some additional risk in your participation in that advanced APM as part of the structure of the APM. So that's how we determine it to be an advanced APM. And the benefit is you do get extra incentives for taking on that additional risk because we're then able to measure quality, cost savings, and overall value-based care. Next slide. So here's just another list of your advanced APMs. I'll run through them. We have the Bundle Payments for Care Improvement Advanced Model, BPCI Advanced. Comprehensive Care for Joint Replacement Model, CJR. Comprehensive End-Stage Care Model, again, that is CEC. The LDO arrangement and the non-LDO two-sided risk arrangement are both advanced APMs for 2019. CPC Plus Model, Comprehensive Primary Care Plus Model, is an advanced APM. The Medicare Accountable Care Organization, ACO, the Accountable Care Organization Track 1 Plus Model, the Maryland Total Cost of Care Model, the Care Redesign Program, and also the Maryland Primary Care Program, Next Gen ACO Model, and then the Shared Savings Programs Track 2 and 3, Oncology Care Model, or what we would call OCM, two-sided risk arrangement, and then the Vermont Medicare ACO Initiative, as part of the Vermont All-Payer ACO Model, are all advanced APMs for 2019. Next slide. So here's the criteria to be an advanced APM. We just went through the list of the advanced APMs, and they all meet this criteria. First of all, advanced APMs build on existing APM structure. 2, to be an advanced APM, you must meet these 3 requirements. 1, it requires participants to use certified EHR technology, and this year it's 75% of the clinicians in your entity. Number 2, provides payment for covered professional services based on quality measures comparable to those in the MIPS quality performance category. They don't have to just be measures on the MIPS list. They just have to be reliable, evidence-based, and valid. Number 3, either is a medical home model expanded under CMS Innovation Center Authority, and currently we don't have any expanded models, or requires participants to bear a more than nominal amount of financial risk. Next slide. And I just talked about this. This is where we talk about the certified EHR technology, that at least 75% of the clinicians in each APM entity must use certified EHR technology to document and communicate clinical care information with patients and other healthcare professionals. Next slide. And if you want to learn more about certified EHR technology, please feel free to go to ONC's website, and you can learn about the 2015 EHR technology certification. And you can also enter in your information and learn about the EHR that you currently use. Beginning in 2019, CMS introduced a specific threshold of cert use as an eligibility requirement for participation in the shared savings program. As a result of that, we removed the ACO quality measure that assessed the use of certified EHR technology, or what those in ACOs would call ACO 11. Participants in the shared savings program that meet the financial risk standard to be an advanced APM must now certify annually that at least 50% of eligible clinicians in the ACO use CERT. Next slide, please. So number 2, we talk about basing payment on quality measures that are comparable to those in the MIPS quality performance category. This is just all background information. I want to make sure that you understand that the model, if the model is open for you to apply to, much of this work has already been done. We have already found the measures, and we've already determined what measures actually fit into that model for the work to be completed. That is for the reporting and the work in the model. This is just for your understanding of how we got to the place of determining those. So we tie payment to quality measures that are evidence-based, reliable, and valid. At least one of those measures must be an outcome measure if an appropriate outcome measure is available on the MIPS measure list. Next slide. And then we also talk about what does it mean to be MIPS comparable. So beginning in 2020, we streamlined the quality measure criteria to state that at least one of the quality measures upon which an advanced APM basis payment must be on the MIPS final list, endorsed by a consensus-based entity, or otherwise determined to be evidence-based, reliable, and valid. So if you see a measure that we're asking you to report on in your advanced APM and it's not on the MIPS final list, it is not endorsed by a consensus-based entity, then you can also look at the determination of its evidence base, its reliability, and its validity by CMS. So one of the 3 must be met. Next slide, please. Here again, we talk about the outcome measures. We talked a little bit about this. It's the same thing. The outcome measure must also be required that it be used by evidence-based, reliable, and valid in meeting those same 3 criterion. MIPS final list, 1. 2, endorsed by a consensus-based entity, or otherwise determined to be evidence-based, reliable, and valid by CMS. Next slide, please. Here again, we talk a little bit about the way that we look at the 3rd criterion of, is it a medical home model expanded under CMS Innovation Center Authority, or does it require participants to bear a more than nominal amount of financial risk? I just wanted to bring to light that all participants in the Comprehensive Primary Care Plus model, or CPC Plus, are subject to the 50 clinician cap. No more than 50 in the CPC Plus model to be considered part of the CPC Plus program. Next slide, please. Here, if you are a medical home, the medical home must be an APM that has the following features. Participants include primary care practices or multi-specialty practices that include primary care physicians. Again, it is a comprehensive primary care program. CBC Plus is a medical home model. And practitioners and offer primary care services. So we talk about an empanelment of each patient to a primary care clinician, or to a primary clinician, not primary care, but primary clinician. So the patient has to be empaneled to each primary care, well, empanelment of each patient to a primary clinician. Just got a little tongue-tied there. So each patient must have a primary clinician in those groups that we just listed. And then at least 4 of the following additional criteria must be met. Plan coordination of chronic and preventative care, patient access and continuity of care, risk stratified care management, coordination of care across the medical neighborhood, patient and caregiver engagement, shared decision-making, and payment arrangements in addition to or substituting for fee-for-service payments. And I just wanted to stop here that you'll see that many of these different strategies to improve healthcare really focus on the patient-centered approach and really focus on the clinicians working for the benefit of the patient and the overall care. Next slide. Again, the medical home model, as we talk about risk, the medical home model financial risk standard, bearing financial risk, it basically means that the medical home model may do one or more of the following if it's an actual expenditure model and it exceeds expected expenditures. Withhold payment for service to the APM entity or the APM entity's eligible clinicians. Reduce payment rates to the APM entity or the APM entity's eligible clinicians. Require direct payments by the APM entity to CMS, or cause the APM entity to lose the right to all or part of the otherwise guaranteed payment or payments. What are we talking about here? We're talking about the benefits of the model to provide risk so that we can know that there is cost savings and that everyone has accountability on the financial side. A medical home model nominal risk standard, the total potential risk that an APM entity potentially owes CMS or foregoes must be equal to or at least 3% of the average estimated total Part A and B revenues of all providers and supplies in participating APM entities for performance year 2019. So again, 3% of the average estimated total Part A and B must be at risk to forego or owe. And then 4% moving into performance year 2020 and 5% for performance year 2021 and after. So just thinking about the 3%, that would be $30,000 on $1 million, just to help with the math a little bit. And again, that would be what would be at risk, but many of the clinicians are doing very well here. Next slide. Here's a general standard for nominal amount of financial risk. Financial risk is basically bearing financial risk means that the advanced APM must do one of the following if actual expenditures exceed expected expenditures. So again, actual expenditures exceeding expected expenditures, which your outlays are, which you spend. That you must withhold payment for services to the APM entity and or the APM entity's eligible clinicians, reduce payment rates to the APM entity and or the APM entity's eligible clinicians, or require direct payments by the APM entity to CMS. In addition, the total amount of risk, the 8% revenue-based standard, is extended for 2 additional years through performance year 2020. Total potential risk under the APM must be equal to, or at least either 8% of the average estimated parts A and B revenue of providers. So again, the total risk must be at least either 8% of the average estimated parts A and B. So 8% of the average estimated parts A and B revenue would be part of the total potential risk under the APM. And that's one of the standards for risk. Or 3% of the expected expenditures for which an APM entity is responsible. So again, 3% of the expected expenditures for which an APM entity is responsible under the APM for all performance years. Next slide, please. Here, Trevi is going to walk us through becoming a QP.
All right. Thank you, Corey. And actually, before we move on from this section, Corey, I see a lot of questions in the question and answer from SSP participants wondering about how they submit their promoting interoperability data. And one of the primary questions is, where do we go for resources to answer this question? And I would point people towards the 2019 Medicare Shared Savings Program and QPP Interactions Guide that's on the QPP site. It's a wonderful little two-page write-up that looks at advanced alternative payment models and those who are in the MIPS APM tracks, and gives you some guidance on how you can submit your quality and promoting interoperability data. So that's where you should go for that. All right, so we'll move along into advanced alternative payment models and how you become a QP. So we have three criteria for becoming a QP. For 2019, performance year 2019, you must receive 50% of your Medicare Part B payments or see 35% of Medicare patients through an advanced alternative payment model entity during at least one of the snapshots. In addition, 75% of practices in the advanced APM need to be using certified EHR technology. And then lastly, eligible clinicians may be QPs through the all-payer option, which is a combination of Medicare and non-Medicare payer arrangements, such as private payers and Medicaid Advantage plans. All right, next slide. Sorry for the delay here. So on this slide, you should see three snapshot dates. So during the QP performance period from January to August, we have 3 dates. And basically, you can think of this as a bicuspid valve, right? It's sort of once the blood flows through, it's not flowing back. So once you get QP status, there's no undoing that status. So you must meet either a patient count or a payment threshold for one of these 3 snapshots, and once you do, you're a QP. So if you meet QP status on the first snapshot, you'll be a QP for the rest of the year. And the same holds true if you miss the March 31st snapshot and the June 30th snapshot, but get the August 31st, you're a QP. All right, we'll move on to the next slide here. So on this slide, sorry for the delay. On this slide, I'll reiterate, for QPs, the first criteria is that you're on an APM participation list. So that's the first thing that we do, is we collect participation lists from our advanced alternative payment model teams. And then if you're on one of those lists or on an affiliated provider list, then you're considered part of that advanced alternative payment model, with one exception, which is that there are some models, for example, BPCI Advanced, where there are participants who are on an affiliated practitioner list and a separate list for participation. And so we will identify the APM entities, we'll use the APM entities participation list to determine QP status. Next slide. So how do we identify eligible clinicians as QPs? One of the criteria is that we look at your eligibility, your attribution eligible patients, and we look at specifically Medicare Parts A and B for the entire QP determination period. We also require that you're at least 18 years, the patient is at least 18 years of age on January 1, and that of that QP performance period, that they're a U.S. resident, And lastly, that they have a minimum of one claim for the E&M service furnished by the eligible clinician or group of eligible clinicians within the APM entity. And we have a variety of procedure codes that we include there. Next slide. So to ensure that we determine the right attribute eligibility for each APM, we may apply certain exclusions or exceptions to the E&M requirements for those eligibility, or those attribution eligible beneficiaries. So we've developed alternative methods for the following APMs: comprehensive ESRD care model, the BPCI advanced model, comprehensive joint replacement model, and the Maryland total cost of care model. So you can find the QP methodology for those models on their model pages out on our CMMI website. If you have follow-up questions about that methodology, contact your model team. Next slide. So after we determine the eligible clinician or the eligible patients, attribution eligible patients, then we calculate a percentage for a threshold score for your APM entity using two methods. The first method is based on Medicare Part B services and the beneficiaries attributed to the APM. And then after that evaluation, we'll use a method where we look at the providers, the QP's participation in other advanced alternative payment model entities. So basically we create a numerator and a denominator here of attributed beneficiaries, and then in the numerator, and then the denominator is the attribution eligible beneficiaries who could potentially be treated. So it's how many are attributed to the advanced alternative payment model entity, and then how many patients could be attributed to that provider. All right, next slide. So we have two methods for calculating a patient or a payment amount calculation and patient count method. The payment amount method here on the left looks at the Part B professional services that I just spoke about and provides a threshold score. And then we also calculate a patient count method, and we give you the most beneficial of the two. So if you're a QP based on the payment amount method, you're a QP, or if you're a QP based on the patient count method, we give you that score. All right. Well, we score you for both, but we give you QP based on the most favorable threshold score that you receive. Next slide. So for performance year 2019, you can see on this slide, we're now at a point where the threshold score for payments through the APM is at 50%, and the percentage of patients through the advanced alternative payment model is now at 35%. You see that that will remain true for 2020 as well, and then we'll move up in subsequent years. And again, we'll take the better of the two percentages when taking into account QP determination. Next slide. All right, so how are QP determinations made for the for our participants. The first step is to determine QP eligibility for the advanced APM entity for the performance year. So on this slide, you get a nice little visual of an advanced APM entity there at the top, or an advanced APM with 3 APM entities underneath, and then eligible clinicians participating in those APM entities. So we score each entity, and then we also score those eligible clinicians participating in the entity. And any clinicians who are participating in an APM entity that achieves the QP threshold, they're QPs. Eligible clinicians who are participating in an APM entity that does not achieve the threshold, they're then evaluated as individuals, and if they achieve QP status, then they're QPs, and if not, then they're that group there down on the left-hand side that are not filled in, who have not met the QP threshold. All right, next slide. The QP performance period. So similarly to MIPS performance and payment adjustments, the QP performance period occurs in the performance period, during the performance period of January 1 to August 31st of the calendar year. And then 2 years later, there's a payment year. So if the QP performance period that we're talking about is 2019, then we have an incentive payment calculation that goes on over performance year 2020, and then there'll be a payment year in 2021. So 2019 is when you'll be doing your work, becoming a QP. 2020 is when we'll do that calculation, and then 2021 is when we'll make that incentive payment. Next slide. All right, so one of the pieces that we want to make sure that folks are aware of is that while we have these snapshots and we try to communicate as quickly as we can, there is a claims run-out period after each of the snapshots. So for this first snapshot between points A and B, point B is March 31st, where the first snapshot is, but there is a 3-month lag there between for claims run-out. So then we end up posting QP determination at point D. And that's true for snapshot 1, snapshot 2, and snapshot 3. Next slide. So if you, again, I'll reiterate, if you reach the QP threshold at any one of the 3 QP determinations, you will receive QP status for that eligible clinician in the advanced APM entity. So eligible clinicians will be notified at that point D in time after the claims run out and after our calculations. Next slide. So what if a clinician doesn't meet the QP threshold or the patient threshold? What happens? So if clinicians who participate in an advanced alternative payment model don't meet that QP threshold, they become partial QPs. Assuming that they're participating in the advanced alternative payment model and they don't meet the QP threshold, they become partial QPs. And a partial QP has a option. They can choose to participate in MIPS, or they can choose to not report to MIPS and receive a neutral adjustment. Next slide. All right, finally, this is a visual of what our QPP lookup resources look like. So you can go to our qpp.cms.gov site, type in your NPI number, and you'll get a display of your participation in the QPP program. So you'll get a list of your where your NPI has been assigned to what TINs, and under each of those TINs you'll see their participation in advanced alternative payment models if that TIN is participating in one. And you'll be able to see your QP threshold scores there as well. So that's a wonderful tool where you can get sort of instantaneous feedback on the current performance year, but also on your participation in QP for previous years.
We will say that currently in the QPP lookup tool under the 2019 performance year, predictive QP results are currently available for advanced APM participants.
Thank you. I used it today, and it's a great resource. All right, so I'll hand things back to my colleague here, Dr. Corey Henderson, and take it away, Corey.
All right, so we're going to wrap up here with the advanced APMs in 2019, talking about all-payer combination option. Let me just explain the two differences. Right now, everything that you've learned today, everything that you've heard today, has been Medicare option. Medicare option is available for all performance years. Eligible clinicians can achieve QP status just by participating in an advanced APM within the Medicare fee-for-service. The all-payer combination option is a little different. It is available starting in performance year 2019. Eligible clinicians can achieve QP status based on a combination of participation in advanced APMs within Medicare fee-for-service, and which means you must be in a Medicare fee-for-service advanced APM first, and you can add other payer advanced APMs offered by other payers. Next slide. So looking at those two pathways, we then talk a little bit about what does that mean to you. Well, one, the all-payer combination option is, along with the Medicare option, one of two pathways that's available to you, which means you combine the two to become a QP. QP determinations under the all-payer combination option will be based on the eligible clinician's participation or combination in the advanced APM. I keep saying that because you must be an advanced APM in order to combine your participation in other payer advanced APM. QP determinations are conducted sequentially. So we start with the Medicare option, and then we apply to that the all-payer combination option. Only clinicians who do not meet the minimum patient count or payment amount threshold to become QPs under the Medicare option, but still meet a lower threshold, can participate in the all-payer combination option, and they are available to request a QP determination under the all-payer combination option. The all-payer combination option, again, begins in 2019 QP performance period. Next slide. So here we're going to talk a little bit about which models are available for the all-payer combination option. Well, because this is more about the payers, we're going to talk about all the models that our advanced APMs are available, but the payer types that we add for the other payer advanced APMs include Medicaid, Medicare health plans, including Medicare Advantage, CMS multi-payer models, and other payer or other commercial and private payers. Next slide. And I'm going to pass this over to Adam Richards and take it from here.
Okay, well, great. Thank you, Corey, for leading us through that. Just talk a little bit about some of the resources that we have available. I know we're getting a lot of questions in the Q&A just around, where can I find information or additional information what we're discussing today. So again, we encourage you to go to the Quality Payment Program website, qpp.cms.gov. We've added several new pages under the APMs drop-down page at the top of the screen. all of which focus on just APM overview, MIPS APMs, advanced APMs, and the all-payer combination option that Corey just mentioned. So there's a lot of really good information out there. We also have a number of resources that are available under the resource library pertaining to, again, APMs and advanced APMs. So highly recommend taking a look at that information as well. And I believe we have a good example of that. If we move forward, where to find that information, it's under the About tab. Of course, Corey mentioned certainly going to the Innovation Center website to take a look at some of the model-specific information. I think that's also a really good resource for folks. I will mention, I know we get a lot of questions just around, I think from folks just participating in MIPS. We get a lot of questions around the changes that we make to the advanced APM track. And as you can see with our webinars, and we've been doing these for several months and even years since the inception of the Quality Payment Program, you do see quite a bit of consistency with the advanced APM track. We make updates that are based on feedback we receive from you all as well as our stakeholders to make sure that we've got the right programs and policies in place. And we add additional advanced APMs as we start to roll out additional models throughout the years. But there is a degree of consistency here. So you will see that within the slides and within the information we present. I think one of the big key takeaways is certainly monitoring the QP thresholds, as those will continue to go up year after year. But that's where I think the all-payer combination option will certainly come into play. This is a plug for certainly looking at that information on the website, but also keeping your eyes open for our all-payer combination webinar that we have scheduled in a few weeks. So let's charge forward to the technical assistance section, just to talk a little bit about some of the on-the-ground support that we have available as well. Go to two more slides to be on the technical assistance piece. I'm sure many of you are familiar with this. We do have free technical assistance that is available to clinicians who are participating in the Quality Payment Program. I know a number of folks who are thinking about certainly transitioning into an APM or an advanced APM would benefit from taking advantage of the Transforming Clinical Practice Initiative, enrolling with the Practice Transformation Network. But if you're still participating, maybe you participate in a MIPS APM, we do have great support for you. Whether you're in a large practice through our Quality Innovation Networks or a small practice through the Small Underserved and Rural Support Initiative, highly encourage you to take advantage of that. Again, qpp.cms.gov is a great resource, as well as our Quality Payment Program Service Center, which is available to help answer your questions. And then, of course, we always recommend certainly connecting with our learning systems and the model-specific support that is available if you already are in a model and you just need that specific model support. Okay, so we're going to charge forward. I think we're going to open this up to the Q&A portion. We have about 10 minutes remaining, so I'm going to turn it over to our operator to help folks get into the key.
We are now going to start the Q&A portion of the webinar. To ask a question, you may ask a question via chat or by the phone. To ask a question via phone, please dial 1-866-452-7887. Again, the number is 1-866-452-7887. If prompted, please provide ID number 5165-1169. The ID number 5165-1169. Once you've joined the conference, please press star 1 in order to ask a question. Again, star 1 to ask a question. We'll pause for just a moment. Our first question is from the line of Sandy Swallow.
Hi, thank you.
Hi, Sandy. Go ahead.
Can you hear me?
Yes, we can.
Okay, great. My question is in regards to that CMS determination of the other payer advanced APMs. My understanding is that the payer has to submit payment arrangement, and it has to be reviewed and approved by CMS, and then they would post a list of the other payer advanced APMs online. Have any payers submitted this information to you? I don't see any posted out there, and maybe I'm missing that.
Yeah, so you can find that information right on qpp.cms.gov by going to the resource library. And in the search, in the search you want to type in determination. If you type in determination or determine, you'll get the list that has been submitted that we've actually posted for those who have been determined to be other payer advanced APMs.
Okay, so I'll go to
Find, yep, resource library.
Yep, I'm there. So I'll type in determine, just type in determine.
Determination or determine, either one, and you're going to find that we have the determinations for the other payer advanced APMs. Or you can type in other payer. Any of the titles that you're looking for, you can type into the search field and you'll be able to find resources relevant to that. Under other payer, you'll see the 2019 list of Medicare health plan, other payer APMs. We also have the 2019 QPP multi-payer other payer advanced APMs. We also have the 2019 Medicaid other payer advanced APMs list.
Okay, I will see if I can find that. Thank you.
And just type in other payer.
Okay, we'll do that.
Thank you. While we go to the next question, just one announcement. There's a typo in the slides regarding the claims runout period for QP determination. So prior years, claims runout was 90 days. Beginning in 2019, claims runout is now 60 days. So we'll make that correction.
Your next question is from the line of Sheila Banyai.
Hello. I have a question about slide 40, the performance period for QPs. Is the QP performance period and the incentive payment base period two different periods?
Yes. So the QP performance period is January 1st through August 31st of the performance year. If you are determined to be a QP during that QP performance year, we then look at the next calendar year, which will be January 31st. Let's take this year as an example. So if you were determined to be a QP in 2019, we then look at January 1st through December 31st, 2020 to base your 2021 QP APM incentive payment on. So the 5% lump sum APM incentive payment bonus is applied to your claims in January 2001 through December 31st, 2020. Does that answer your question?
Do you hear me?
No.
Yes.
Oh boy.
Is there a second part?
Yes, there is. Can you hear me?
Yes.
Okay. So, assuming we're in 2019 still, the 2019 is a performance period. You're told you're a QP. In 2020, that determines how much your payment is going to be, and you get paid it in 2021.
Correct.
And that incentive payment base period, when did you say that was from? January to what?
January 1st, January 1st through December 31st.
Thank you very much.
Thank you.
Your next question is from Chu Trung.
Hi, I'd like to say thank you for holding these. They are very informative. I have a question about QP status. So I understand that you would lose your QP status if your ACO terminates within March 31st to, I think, September 31st. But you would retain your QP status.
So let me just clarify. You would lose QP status if your ACO terminates prior to August 31st.
Okay, August 31st. You would retain your QP status if your ACO was one that had extended its contract for 6 months, but then finished June 30th. That's my understanding, but our ACO is a little bit different, so I needed a clarification. Our ACO is doing an early renewal, and so they're starting at Basic Track E on July 1st, but we will not be part of the ACO when they do the early renewal. would we retain our QP status for 2019?
When would you be joining the new ACO?
We were part of the ACO. The ACO started in 2018. It was a Track 1 Plus, so we were QP status in 2018. Preliminarily, we're a QP status in 2019, but the ACO will do an early renewal and change from Track 1 Plus to Basic Track E. We will not be part of the ACO anymore effective June 30th, 2019.
So we'll have to take that back. I believe, though, if the ACO is not extending, then you would lose QP status. That's my interpretation of it. I would urge you to submit that question to the Service Center, and we'll follow up with our policy folks. I know we're still working through some of those SSP pathway to success rule issues, and so that's one of the things that we're currently working on. I think the information I gave you was correct, but we will take that back to the team if you would like to submit your question through the Service Center as well.
I have submitted to the Service Center. I received an answer very similar to yours. Someone from the ACO submitted a similar question, and they received a different answer, basically saying QP status would be retained.
I'm going to give you the answer. I'm going to give you the answer based on what's in writing, and I'll tell you where to find the answer. If you go to the Shared Savings Program and QPP Interaction 2019, all you got to do is go to qpp.cms.gov, look for the SSP and QPP Interaction Guide, and when you get the document, you'll find it on page 4. You'll find underneath qualifying APM participant in advanced APM tracks, there is a box that has the answer for you. It says if an ACO is in an advanced APM track that terminates its participation in SSP after March 31st and before August 31st, its eligible clinicians will lose QP status and will be subject to MIPS and scored under the APM scoring standard. These clinicians should continue working with their ACO to report their quality measures. However, the next line says, these clinicians will get full credit for IA and should report PI at the group or solo practice. While they no longer may be eligible to receive an APM incentive payment, the eligible clinician will be scored under the APM scoring standard and may earn a positive MIPS payment adjustment. But the catch here is, eligible clinicians and ACOs that complete their agreement with the SSP program, including ACOs who extended their agreement 6 months to June 30th, 2019, will maintain their QP status. Eligible clinicians and ACOs that start July 1, 2019 will have their status determined based on August 31st snapshot only.
Also, would it be possible, do you have access to that Service Center ticket number? We can also follow up as well.
I do. I can give you that ticket number,
okay,
or I can email it to you.
Yeah, you can, if you have it handy now, I'll take it now.
Okay, I do have it handy now. It is CS0535322.
CS0535322. Okay, we'll follow up. Thank you.
All right, thank you.
Your next question is from Carly Michaela.
Hi, yes. When can we expect to receive our 5% QP bonus from the 2017 performance year?
Good question. We plan on making this payment this summer, and the payment will be paid to the QP's 10.
Thank you.
Okay. And we are at the top of the hour, so we are going to wrap up for today. Thank you all for joining us. Keep a lookout for the all-payer combination option webinar that's coming right around the corner, and be sure to sign up for the QPP listserv. Thank you all again, and we'll talk to you again soon.
Thank you. This concludes today's conference. You may now disconnect. Speakers, please hold the line.